Good morning, everyone. This is Mark Erkin, and welcome to our Friday morning session for TIRO MDS. We have a really outstanding presentation this morning with a wonderful panel, and I think it's really will be outstanding information for everyone and extremely thought-provoking. I am really pleased to introduce Ann Sosa, who is the Leon Goldman Distinguished Professor of Surgery, as well as the professor in the Department of Medicine, as well as chair of the Department of Surgery at UCSF. She is also affiliated faculty for the Philip Lee Institute for Health Policy Studies. As I am sure all of you know, she is widely recognized for her expertise as an endocrine surgeon, as well as an NIH and FDA-funded investigator. She is a prolific author with over 350 peer-reviewed publications, as well as 80 book chapters, and she has authored or edited 7 books. Dr. Sosa is president-elect of the American Thyroid Association, where she serves on numerous committees, and perhaps most importantly, she is chair of the Guidelines Committee charged with writing the next update for differentiated thyroid cancer. She is highly decorated for her contributions in the field of endocrine surgery, as well as her role as an educator. It is an honor to have her give this morning's lecture on disparities in differentiated thyroid cancer care. We are also joined this morning by 2 very distinguished panelists who will be helping to generate a discussion at the end of Dr. Sosa's lecture. Both of them are members of TIRO MDS board. Dr. Fabian Pitoia is the head of the thyroid section of the Division of Endocrinology and the investigation area coordinator at the University of Buenos Aires, where he is also professor of internal medicine. Dr. Pitoia is president-elect of the Latin American Thyroid Society. And finally, Dr. Camilo Gonzalez-Velazquez is a frequent contributor to our Friday morning program. He is professor of medicine at the Universidad Autónoma de Nuevo León in Monterrey, Mexico. He is also an executive member of the Thyroid International Recommendations Online. And so, as always, I would like to encourage all of our participants to send in their questions for the panel, particularly for Dr. Sosa, and use the Q&A function. And I will do my best to get those questions out and answered by the end of the hour. And so, in the interest of not taking up any more time, I want to thank you all for joining us, and particularly thank Dr. Sosa for getting up at an ungodly hour on the West Coast to deliver this wonderful lecture. So thanks very much. And Julian, go ahead and take over here.
All right. So first of all, good morning. It feels like it's good night, but it's good morning. It's dark here in San Francisco, and unfortunately the coffee shops are not yet open. So please excuse any sort of slowness this morning. I'm still sort of waking up. Happy New Year, and thank you to Dr. Erkin and the THANC Foundation for the opportunity to discuss with you disparities in differentiated thyroid cancer. This is something that I have been very passionate about for a very long time, and perhaps the silver lining of the pandemic is that disparities in thyroid cancer care and virtually every aspect of healthcare have been unmasked, and I believe there is accelerating interest in these issues and commitment to remedying them. So with that, I will begin. And as also part of my introduction, I do want to give you my pronouns. You'll see them on my Zoom window. My pronouns are she, her, hers, and we'll be talking about the importance of pronouns a little later on in the presentation. These are my disclosures. They pertain to medullary thyroid carcinoma, and the overwhelming majority of my talk today will be focused on differentiated thyroid cancer. I also feel like this invitation is so special because it is occurring during January, which is Thyroid Awareness Month. So happy Thyroid Awareness Month. And I'm certainly spending as much of January as possible disseminating information about benign and malignant thyroid disease and advocating on behalf of patients who have those. So to start out, these are our learning objectives for the next 45 minutes. One, to recognize health disparities, especially those that have been unmasked by the COVID-19 pandemic. Two, to summarize some of the health disparities, by no means all of them, we don't have time for that, but some of the health disparities that have been observed around the incidence and management of differentiated thyroid cancer. Three, to interpret the evidence that underpins these observations. And finally, I think there's only so much time you can spend talking about a problem and documenting the problem. I hope ultimately we can accept that there is an epidemic of disparity, and rather we can finish by focusing on the development of a toolkit around action. So there's nothing new about disparities. These kinds of disparities have really existed over centuries. Fortunately, we're talking about them more. The NIH has, for many decades, thought about and supported science around disparities research. It has defined a number of populations that are at risk for health disparities, whether it's thyroid cancer or other diseases. Among those populations at risk are Blacks and African Americans, Hispanics and Latinos, American Indians, Alaska Natives, Asian Americans, Native Hawaiians, and other Pacific Islanders, socioeconomically disadvantaged populations, underserved rural populations, and sexual and gender minorities. And we're going to walk through many of these areas over the course of this talk. It's important to understand that much of the US population is in these underserved or vulnerable groups. 40% of Americans today self-identify as non-white. 19% live in rural areas. 34% have public insurance, and at least, almost certainly more than 3.8% are LGBTQ+. So as I said, I've been thinking about health disparities for a very long time in endocrinology and endocrine neoplasia. This was a scientific statement that I was privileged to participate in, issued by the Endocrine Society back in 2012, thinking about all the different health disparities that can be found in a variety of endocrine disorders, largely focused on diabetes, but also this statement touched on gestation, on osteoporosis and thyroid cancer. But what I really liked about our work in this statement is that we created this framework for thinking about disparities, starting with what we called proximate factors. Those pertain to the biology of disease, genetic pathways, the human response to underlying biologies, extending then to individuals' risk behaviors, including their demographics and social factors that impact life. Then moving into more intermediate factors. These are the physical context in which we live, like our neighborhoods, the social context. So that's about social networks, socioeconomic status, and our healthcare context. That's access to care, the quality of care we receive, patient-provider relationships, and then ultimately very distal factors. Those are at a population level where we think about poverty, public policy, prejudice, and culture. Today, I'm going to largely focus on intermediate factors, which indeed are modifiable and modifiable by our scientific community. This is all very timely because just earlier this month in Thyroid, this paper went online from Dr. Wartofsky and his group in Washington, looking at sex differences in differentiated thyroid cancer. And they were focused in this study on proximate factors. So that's the biologic profile of disease. It's not going to be the focus of this talk, but it's interesting to think about. They looked at epidemiology studies in differentiated thyroid cancer. And what was interesting in their exhaustive analysis is that they showed very inconsistent results regarding sex differences in disease-specific survival. And what they described is the fact that sex disparities appear to be age-dependent. The greatest differences are, in fact, during the reproductive ages. Specifically, it is women less than 55 years who have greater disease-specific survival than their male colleagues. And then this sex difference disappears in the elderly. And of course, many of you are familiar with sex differences with regard to survival from thyroid cancer, but I'm not sure all of us understand that it really needs to be thought of in different subgroups, those who are of reproductive age and then those who are above reproductive age. So it's a very nuanced conversation. Well, then we're going to be pivoting and focusing more on these provocative intermediate factors. This is a Guardian article that appeared just a couple of weeks ago about a study that came out in JAMA Surgery, not specific to thyroid surgery, but it was very interesting. It was a study out of Canada, out of Ontario, looking at more than 1.3 million patients treated by nearly 3,000 surgeons. And they were looking at the association of surgeon and patient sex concordance to see if there was any association between sex concordance and the patient's risk of developing a complication or dying. And the findings were extraordinary. Women operated on by male surgeons are 15% more likely to have a negative outcome, and shockingly 32% more likely to die than those operated on by female surgeons. In contradistinction, men operated by female surgeons saw no increased risk. Obviously, these are incredibly worrisome data, as surgery is still very much a male-dominated world. And I will say these findings are not unique to surgery. Similar results have been described in the past for hospital medicine. And so what is the implications of this? So I'm often on social media. Many of you may know me more from social media than from my scholarship. But Dr. Williamson said, maybe we can start titling these reports, quote, female surgeons, lower complications, and still lower salaries. Well, let's now talk about COVID. And I would say that COVID-19 has highlighted disparities, and perhaps that is the silver lining, if there is a silver lining, of this crazy pandemic. I live in San Francisco, which is very interesting. It is a minority majority state where Latinos make up 39% of our state, 15% are Asian or Pacific Islander, and 6% are Black. So it's really a unique state where we're always thinking about and talking about healthcare disparities. And this study looks at COVID-19 hospitalization and death rates among patients on the EMR by race and ethnicity. And what you can see is both the blue hospitalization rates and the death, or shown in orange, are very different based on the race and ethnicity of the patients, where Blacks, Hispanics, and Asians have significant elevation in both. Indeed, for Hispanics, their rates of hospitalization are 4 times that of white colleagues. Well, here is San Francisco compared to a number of neighboring counties, looking at racial disparities, again, in COVID-19. And you see right in our local neighborhood, the COVID-19 case rates vary significantly based on the race and ethnicity of the patient, with Latinos in particular experiencing the highest case rates. And when it comes to death, our Black patients are experiencing significantly elevated death rates. So profound healthcare disparities right in our local neighborhood. Well, we've started to focus now and be able to assemble data, not just about COVID-19 infection rates, but also about the impact of COVID-19 on patients who have complexity and severity of illness, and specifically a cancer diagnosis. I think this was a really interesting retrospective case control analysis of patient electronic health records that included more than 73 million patients from 360 hospitals and 317,000 clinicians across all of the 50 states. And what you see is that patients with a coincident cancer diagnosis and COVID-19, these two things tend to go hand in hand. And what you see is that the highest association, really pronounced at an adjusted odds ratio of 19.1, the highest rate is for leukemia. The lowest is for thyroid cancer, but nevertheless, even for patients with thyroid cancer, the risk of developing COVID-19 is escalated with an adjusted odds ratio of 3.19. Not shown in this JAMA Oncology paper is the fact that these associations between COVID-19 infection and cancer is particularly, or are particularly pronounced in African American patients. Well, the health disparities pandemic certainly started well before COVID-19. And it really crosses multiple diagnoses. For Black Americans, they are 30% more likely to die of cardiovascular disease, 2 times as likely to die in infancy, 2 times more likely to die of asthma, and the observations go on. Similarly, Latinx Americans, 40% more likely to die from stroke, 2 times more likely to die from hepatocellular carcinoma. So again, for these 2 racial ethnic groups, profound health disparities that extend well beyond the pandemic, and which in fact are a pandemic. Well, a lot of inequities like this are believed to be associated with the ability of Americans to pay for their health care. And sadly, in this country, so many Americans are either uninsured or underinsured. And these are some data from 2018 showing uninsured rates among non-elderly, so non-Medicare individuals. And you see, compared to white Americans, Americans from these underrepresented and vulnerable populations are much more likely to be uninsured. Well, all of these things are really largely based in that intermediate factor area. And if we look in this area, you will see that according to the Green Lining Institute, about 40% of the factors contributing to disparities are related to social and economic factors, education, job income, and family and social support structures. About 30% are behavioral. So these are things like tobacco and alcohol abuse, diet, and exercise. Just 20% are believed to be related to access to care and quality of care. And finally, about 10% likely associated with things like air and water quality, housing, and transportation related issues. And I found this very interesting because really I thought clinical care would somehow be bigger than it likely is. So what is my personal take? And I'm going to give you a lot of personal narrative in all of this. All of us have implicit bias, and I probably have implicit bias. And so this is taken from a 2016 commentary that I wrote for the journal Thyroid with colleagues at Duke, thinking about differentiated thyroid cancer and disparities. And these are three things that we said in that commentary: racial and ethnic minorities, as well as the socioeconomically disadvantaged. Patients with differentiated thyroid cancer are more likely to be diagnosed with advanced disease and receive suboptimal treatment compared to their white counterparts. Black and Hispanic patients continue to be at disadvantage for many forms of thyroid cancer treatment, and especially surgery. And post-thyroidectomy, Black, Hispanic, and Asian patients have a higher likelihood of undertreatment with radioactive iodine. Well, this is an interesting study from 2019. It published in the journal Cancer, looking at epigenetic features in African Americans and looking to see whether there are biologics, so we're now going proximal, biologic contributors to observed higher mortality rates for a number of different cancer types. Two databases were deployed from the United States, the SEER database shown on the left, the National Cancer Database shown on the right. And I'll just highlight to you for thyroid cancer, you see that African Americans experience a higher risk of death from cancers of the thyroid gland. And this is consistent across both of these national databases. And almost certainly this is in part, at least, related to the epigenetic profile of their tumors. Specifically, the molecular features of more than 5,000 tumors were analyzed in genetic ancestry data that were available to the investigators, and genes were identified with altered DNA methylation along with increased microRNA expression levels unique to African American patients. And it was found that these indeed were associated with a variety of different resistances to cancer drugs. And this was found to be true not only for breast, kidney, and prostate cancers, but also for thyroid cancers, shown circled in red. Well, there is a significant difference in stage of presentation that exists among different racial groups. And again, I keep coming back to California because we are particularly diverse in California. And these are data from 2014, looking at the California Cancer Registry. And what you can see in this table taken from that manuscript is that patients who are Hispanic and Asian and Pacific Islander, they more often present with regional, meaning cervical metastatic thyroid cancer. And also, and now especially in Black patients, they present with more extracervical distant metastatic disease as compared to white patients shown in the first row. So a later stage in disease, which could in part be related to the underlying biologic profile, so that's a proximate factor, or it could be related to compromised access to care. And are there a sequela of this later presentation? And unfortunately, they are. African-American patients as well, not shown in this figure, but as well as patients with lower socioeconomic status have compromised outcomes here. You see that Black patients have significantly, clinically and statistically, significantly lower survival compared to white patients. It's interesting that Asian and Pacific Islanders appear to have superior survival. Well, let's focus on something that I know about more, and that is surgery. And, you know, there is what I would say is a very robust body of evidence that exists, demonstrating that surgeon experience as measured by surgical volume is associated with, on average, superior outcomes for patients. And this study is now more than 20 years old. I don't know, I must have been 5 when I wrote this paper, published in the Annals of Surgery. But this was one of the very earliest explorations in any surgical discipline, really very interesting. Surgery was late to health services research. Looking at the race and ethnicity of thyroid patients with the volume of surgeons, starting on the left with the lowest volume surgeons doing just 1 to 9 thyroidectomies per year, going up to the highest volume surgeons, more than 100 cases per year. And of course, what you see is that white patients are less frequently operated on by the lowest volume surgeons and more frequently operated on by the highest volume surgeons, certainly compared to Black and Hispanic patients. Well, we then looked at a time trend analysis to say, are things getting better? The good news is that over the last 20 years, things have gotten better, but not at the same rates. This figure on the upper right shows that the proportion of thyroidectomies performed by low volume surgeons is decreasing across all race groups. However, the decline is greatest here for white patients and smallest for Black and Hispanic patients. Similarly, this figure in the bottom right shows that there is an increasingly widening gap in access to the highest volume surgeons between white patients, shown here, and Black and Hispanic patients, shown here. Kind of discouraging. And what are the implications of this paucity of access to high volume surgeons? What it means for Black and Hispanic patients, perhaps, is it is associated with a greater cost of care, longer hospital stays, and higher complication rates. Now, these analyses, now done 20 years ago, so please forgive me, were relatively crude. And we've been working to update them over the last 20 years. And we've become more sophisticated in our analysis of the association between surgeon experience and patient outcomes for patients with thyroid disease and thyroid cancer. Well, as I said, there's a lot of variability from the literature in surgeon volume thresholds. And we're thinking more about surgeon volume thresholds in the United States because if insurers can identify a volume threshold that is associated with superior outcomes, it can be tied to referrals and reimbursement. And these kinds of thresholds exist for many different kinds of procedures. They, until recently, have not existed for thyroidectomy. Well, thyroid surgery and volume of thyroid surgery, until recently, for whatever reason, has not been thought of as a continuous variable, which of course it is. I do 50 cases, she does 25 cases, he does 71 cases. Rather, in the literature, it has typically been thought of as a categorical variable, broken up in a variety of different ways. The problem with treating volume as a categorical variable is it tells you a lot about low and high outliers, but it tells you very little about surgeons who have intermediate volumes. So who cares if there's a minimum volume of thyroidectomies that should be performed to optimize patient outcomes? Well, we all should care. And the reason is in 2015, this all started with 3 institutions, Johns Hopkins, Michigan, and Dartmouth, that asked their surgeons to take a volume pledge. A crazy idea, but what the take the volume pledge was is that if a surgeon did not perform some minimum volume of a procedure, even if she or he had spent all of their lives training to do that procedure, but if they're no longer actively performing enough of them, they had to terminate their practice in that arena. So very controversial. Well, let's look at this idea of surgeon volume as a continuous variable looking for a threshold effect for the United States at a population level. And this is the distribution of thyroid surgery volume based on surgeons highly skewed to the left. Well, we looked for a threshold in some conventional ways using unadjusted and adjusted analysis. But then we did something kind of cool. And if you're not asleep already, please don't go to sleep because it's actually kind of simple. And that is we deployed restrictive cubic splines. Well, let me explain them very simply to you. So multivariate regression analysis makes a big assumption, and that is that there is a linear association between independent and dependent variables. So what does that mean? So you're driving super fast on the highway and you hear a siren behind you, the police have caught you, and you slam the brakes on to stop. What we know is that the faster you were traveling, the longer it takes to stop your car. So that's a linear association. Well, I was born in Montreal, and in Canada, all we think about is cold and colder. So these are the temperatures in Montreal by months of the year. And nothing surprising, it's cold in July and it's even colder in January. But there is no linear association between calendar month and mean temperature. So what do restrictive cubic splines do? They relax the assumption of linearity that regression analysis otherwise makes. Okay, so that's what a restrictive cubic spline does. So now let's look at surgeon volume and patient outcome as measured by complication rates. And what we see here is that surgeon volume, increasing surgeon volume confers benefit on average to patients with a reduction in complication up to the number 25. After 25 cases per year, there is a muting of this volume outcome association, the first time that this has been shown. And for the first time, we have a definition for what a high volume thyroid surgeon is. So we now at a population level can take a cohort of patients who undergo total thyroidectomy and divide them into low and high volume surgeons based on whether they do or don't perform at least 25 cases per year. And what we now see is that if a patient sees a low volume surgeon, they on average will have a 55% increase in the risk of a complication compared to a patient who sees a low volume surgeon. Similarly, length of stay and costs are increased as well in the hands of low volume surgeons. Here you see perhaps the most disturbing statistic I'm going to show you today, and that is patients in the United States are more often than not having surgery done by these low volume surgeons. And 51% of all surgeons in the United States do just one case per year. Here you see that dose response effect with increasing cases, declining complication risk. I'm not saying this proves causation, but it certainly suggests a very strong association. So here is a big source for disparity in outcome, right? Patients who are left seeing low volume surgeons on average have reduced or compromised outcomes, longer hospitalization and higher costs. And that is the majority of Americans having thyroid surgery. So huge disparity in surgical outcomes. Does anyone care other than those of us on this Zoom? You betcha. The New York Times picked up this study as well as the Washington Post. Why? Because thyroidectomy is one of the 10 most commonly performed operations in the United States. Well, we are getting more and more sophisticated in how we are thinking about issues pertaining to healthcare disparities. And this is a study that was published just a couple of months ago in JCE&M by Megan Haymart's group at the University of Michigan. And what the authors did was they took patients from Georgia and Los Angeles counties who had been captured in SEER, and they surveyed physicians and surveyed patients, asking the patients who'd been captured in SEER and who had a diagnosis of thyroid cancer, who had counseled them and who had treated them for their thyroid cancer diagnosis. And they divided treating physicians into primary care physicians, into endocrinologists, and into surgeons. And the first thing you see is that a large proportion of the primary care physicians who were left discussing diagnosis and treatment with patients either were uncomfortable or very uncomfortable with the discussion they were left to have with the patient. And does it matter what the patient looks like or what their background is that associated with who was discussing diagnosis and who was discussing treatment? Definitely. Here on the left, we see the specialty of the physician and who informed the patient about the thyroid cancer diagnosis. And what you see is that Hispanic and Asian patients were more likely to receive their diagnosis from a primary care physician as opposed to a specialist. And remember, the primary care physicians are frequently uncomfortable discussing these things with their patients based on the last figure. When we then look at the specialty of the physician discussing treatment, actual management of the disease, you see elderly patients are more likely to be left talking to a primary care physician, and Black, Hispanic, and Asian patients, again, more likely to discuss management for their thyroid cancer with a primary care physician as opposed to a specialist. And again, you have to wonder whether this is potentially contributing to the quality of care that they receive. And what we know is that practice guidelines are not uniformly followed by all physicians in the United States. And it is elderly patients and patients with Hispanic origin who are more likely to receive care based on this SEER analysis from physicians who are not practicing in accordance with ATA guidelines. Well, what about differences in cancer identification? What does that have to do with healthcare disparities? So it's very interesting. Here on the left, we're looking at the incidence of papillary thyroid cancer based on the size of the tumor. And what you see is that whites in particular have this very pronounced increased incidence in the identification of the smallest tumors. Well, then in the figure on the right, if we look at papillary thyroid cancer incidence overall, and looked to see whether the difference in incidence is associated with overdiagnosis, meaning potentially these tumors less than 2 centimeters, or appropriate diagnosis, that is tumors greater than 2 centimeters. It is the smallest tumors shown in black that set whites apart from blacks with regard to this higher incidence at 67.5% versus 39.7%. There's actually very little difference when you look in incidence when you look at tumors that are larger than 2 centimeters in size. Well, it's also interesting to look at gender differences in thyroid cancer and their association with these small tumors, this idea of overdiagnosis. And when you look at the tumor histology, you see that women in their lifetime are more likely to be diagnosed with a small papillary thyroid cancer than men, perhaps because of surveillance for other diseases like breast cancer, for instance. When you look at other histologies, it is much more balanced between women and men. And then when we come over here on the right to look at women to men ratios for thyroid cancer incidence, you see it is very pronounced, elevated women to men ratio for incidence, but mortality and prevalence are much more balanced. So the incidence of more lethal types of thyroid cancer and thyroid cancer mortality are similar by gender, but this is not true when we talk about overdiagnosis and the diagnosis of small tumors. Again, a more sophisticated and nuanced examination of health disparities. Certainly the financial milieu we work in impacts all of this. This is a study in JAMA Surgery from 2020 looking at Medicaid expansion. And what you see is that in states where there was Medicaid expansion, you see an increase in the diagnosis of thyroid cancer, perhaps from better access to physicians. But fortunately, there was no change in the size of the tumors, and therefore this did not contribute to overdiagnosis. Many hypothesize that there is a rural-urban divide in healthcare in the United States, and that this is another foundational underpinning of healthcare disparities. And these data suggest that may in fact be true, where thyroid cancer incidence is significantly higher in urban areas of the United States as opposed to rural areas shown in blue and green. And are there implications for that? There might be. And what you see here, perhaps disturbing, is that survival is superior from thyroid cancer in urban areas as compared to rural areas. Well, the characteristics of the patients, again, not just the characteristics of their providers, almost certainly plays a role in all of this. And what Dr. Haymart, again, Megan Haymart from the University of Michigan, has shown is that less educated patients and Hispanic patients are more likely to report inaccurate risk perceptions. Specifically, they overestimate their recurrence risks. This is also true with those patients with lower education level, and they also are more likely to overestimate their mortality risk. And what we know is that this overestimation of risk leads to more worry and therefore lower quality of life. And so we start to see multidimensional disparities related to race, ethnicity, and educational level. And sadly, the story is also true for children. Children from lower income families and those lacking insurance are more likely, based on this 2017 study, to present with more advanced disease. Obviously, you can only be stage 1 or 2 when you are young, more likely to present with advanced stage disease, with lower insurance, lower income, and lower education. And these patients, young patients, children, also experience longer periods from the diagnosis to treatment, so potentially delay in care. Fortunately, in children, we have been unable to describe compromise in long-term outcomes. So let's finish with our action plan. The first I will say to you as a surgeon scientist is we have so many opportunities to do more and better health services research. And people like Megan Haymart and her colleagues are pushing the envelope in how to ask better questions. These are some of the things that I think could be done to improve examination of cohorts. We should get community physicians involved. We don't live in an ivory tower or bubble. We should be focusing on health disparities. We should be thinking about patient-reported outcomes, the view through the patient's lens. And we need to break down monolithic racial and ethnic categories into nuanced subgroups. And around that point, you will see I've presented a lot of data today looking at Asian Americans, Asian and/or Pacific Islanders as some kind of homogeneous group. They are not that. We know that Asian and/or Pacific Islanders are at high risk for thyroid cancer, but when the data are disaggregated, there are clear differences in risk based on subgroups. And here I will just highlight for you, Filipinos are at extraordinarily increased risk for the development of thyroid cancer as compared to other subgroups within the Asian thyroid cancer population. So we have so much work to do, again, nuanced work. Well, what can each of us do as a clinician each and every day in our clinics? Here's the toolkit I put together to help you think about things. First of all, we must as a community recognize these disparities and we must be committed to reducing them. Talks like this hopefully will raise awareness. We need to increase our fund of knowledge and skill set with cultural competency training. Individual provider performance data, I believe, should be stratified by our patients' race and ethnicity. We need to implement basic quality improvement structures and make equity an integral component of quality improvement. Equity is a quality metric. We have to design interventions and specifically for unique microclimates in each of our institutions and practices. We have to not only implement, but then do the scholarship to evaluate and adjust when necessary the interventions we've designed based on data. And we have to assure durability of the changes we make by institutionalizing them into standard practice. And then we need to share those best practices within the thyroid community. And finally, we should be actively incentivizing providers to be equitable in the care they provide. What are some things we are doing at UCSF Surgery? And I want to finish here. Well, we are addressing patient-facing issues such as unconscious bias, microaggressions, structural inequity with these 4 interventions. 1, avoiding using stigmatizing language. We use pronouns appropriately. 2, we assure that patients who do not speak English have 100% access to translators, and we document that in the EMR. It must be documented that they had access to a translator. We include our staff in all our DEI efforts. And finally, we are now at UCSF Surgery in our department debuting a diversity dashboard to report out individual providers as well as service line performance. And I'm wearing today, I don't know if you can see it, my little pin, but all of the members of our department at UCSF Surgery wear proudly a UCSF Department of Surgery pin, but more importantly, it has their pronouns on it. We introduce ourselves by our pronouns, we ask our patients their pronouns, and that is how a consultation begins. So finishing, this is a social media expert from Twitter. I love Twitter. So one of my colleagues at the University of Cincinnati said, what's the greatest advancement that has occurred in the field of surgery over the last 30 years? People said laparoscopy, robotic surgery. I said the diversification of surgery, hands down. This is what UCSF endocrine surgery may have looked like even a couple of years ago, but this is the way we want to look today. We want to be diverse in all dimensions. With that, thank you again for the privilege of speaking.
Dr. Sosa, thank you so much. That was absolutely an absolutely outstanding and extremely provocative lecture, and brought so much information in to our listeners. I have to, before I get into specific questions, I've got to circle back to what you stated at the outset regarding the outcomes for women who are operated on by male surgeons. That is absolutely astonishing. I don't know if you want to give a little bit of color to that, but I'm shocked by that.
Yeah, this study from the province of Ontario, but it's a population level study, was super provocative and distressing because the directionality was all one way, as I showed you. It was women patients having care by male surgeons who had the compromised outcome. The flip was not the case. It was the outcomes were the same. And of course, the best outcomes were seen when there was concordance between sex, or gender, between the patient and their surgeon. So there was no really good explanation because it was a population level administrative database study. But I have to tell you, and I think I mentioned this is not just true for surgery. The same has been shown in hospital medicine. So, you know, I think what probably needs to be done is some qualitative or mixed method studies talking to patients about their, and surgeons, talking to them about their experiences and about their respective approaches to care.
Excellent. I'd like to invite Dr. Pitoia and Dr. Gonzalez-Velazquez to give us some questions and commentary. Before I do, one of our listeners has sent in a question that highlights how absolutely spectacular this presentation was, but wants to talk a little bit more about urban versus rural incidence of thyroid cancer and speculation as to what component environmental exposure may have in terms of risk here, other than radiation exposure, occupational hazards, et cetera. Do you perhaps, can you comment on that, or is that too broad of a question here?
No, it's a good question. And the study did not delineate the possible explanations, whether it was environmental exposure, access to care, or whether there were correlates to the rural-urban divide based on race, ethnicity, education, socioeconomic status, insurance status, and the like. I do think it's very provocative the way Dr. Smith, I think, asked the question, because, you know, we've been looking at the microclimate, the microenvironment, and the biosphere to see what could, what in our environment could explain disparities, increasing incidence. Radiation exposure has gone up for sure, but that does not appear to be the explanation for increasing incidence. Why? Because the RET-PTC mutation has not gone up in incidence. In fact, it's gone down, while BRAF V600E going up, and of course not associated with radiation. If you ask me, this is one of my little pet peeves, I believe obesity definitely explains a lot of environmental exposure. Unfortunately, is modifiable. Obesity probably now explains about 25% of incident thyroid cancer cases, and obesity is associated with more advanced, more aggressive disease. The other thing really interesting to me are flame retardants. And there are data from at least 1 or 2 now case-controlled studies suggesting that papillary thyroid cancer is associated with flame retardants, which can be found in upholstery, as well as in electronics that are black in color, like this giant computer screen I am looking at right now. So I'm a little concerned about that, but so great question, not answered by the study I showed.
Great. Fabian or Camilo, would you like to comment?
Yeah, sure. Congratulations on this wonderful and complex analysis of all these variables put very clearly here. And of course, and as this is a very complex interaction of variables, it's very difficult to establish exactly at what level each of these variables are acting in the different outcomes in this group of patients. But I was really very surprised of your analysis of the number of surgeons to define this intermediate group with between 20 and 100 or 70 surgeries per year. And I think that, I don't know what you think about this, that this is a major point in changing, because you pointed out that you have almost 55% of surgeons who had only one operation per year operating patients, and those were those who had the most adverse events. So don't you think this is the first point to act?
Yeah, yeah, great question. So, and unfortunately, when it comes to this, I'm not smart and powerful. Like, I don't run our payers, like whether it's Medicare, Medicaid, or you know, high-level policy that could make the changes that would address your observation. First of all, we do not have, in the United States at least, enough high-volume surgeons. Those high-volume surgeons that we train, we keep in high-volume centers. So we do not geographically distribute them. So the problems are with too small an N and maldistribution. And then in the United States, we have a healthcare system that has created really insurmountable barriers for patients to go out of network. Now with the pandemic, you can go out of network virtually for your consultation, which has been terrific to address this issue, but the travel has been compromised. And if you can't go out of network, then you don't have the access you need. And that, I think, is why we are left seeing so many patients seeing the low volume surgeons. Ultimately, I think this is a question that has to be addressed by policymakers, payers, and educators, meaning how we train surgeons and where we send them.
Thank you.
Great.
First of all, my first thought when I was listening to your lecture was, who needs coffee with this type of lectures? You know, this is a very thought-provoking lecture, and I thank you for that. And the first thing that always comes to mind when I hear about disparities is what happens when we take this scenario outside of the boundaries of the US. And I just see the disparity going bigger. And education was one of those factors you talked about. And it works both ways, for the patient and for the doctor. And sometimes the education is the ability of having us have physicians that work in the community adopt the guidelines and what the guidelines are doing to help close this disparity gap. So what are your thoughts about that? What do you think the guidelines should do, or what should we look at in the guidelines to try to close these disparities and better serve our patients?
Yeah, thank you for that. So as many of you know, or you heard from Dr. Erkin, we're currently working on the next iteration of guidelines for thyroid nodules. They will be separate from the guidelines that I'm co-chairing for differentiated thyroid cancer. So in response to your observation one, we have more international representation on the guidelines. Secondly, we have a methodologist who helps us think about all the different issues, many of which are not just related to pathophysiology and biology, but issues like this. How do we build them into the study? Third is we have a patient on a representative of FICA is on the guidelines who speaks up and speaks out his mind about what the patient perspective would be, because in the end, the patient should be at the epicenter of everything. What we don't have, and which I called out as a weakness of a lot of the research that has been done, is the absence of a community representative. And I do think that is something that needs to be remedied going forward, because so much care is being provided in the community. And I actually think we don't well understand it, and therefore we can't well offer advice on how to improve it.
Terrific. I have to say I am just incredibly disappointed that we do not have more time to explore some outstanding questions and comments that have come in from our audience. And there is so much more for us to pursue in this just incredibly wonderful presentation. Unfortunately, we are up against the 9 o'clock hour, and as a result, we will certainly have to close this broadcast. But once again, to Dr. Sosa, to Dr. Pitoia, Dr. Gonzalez-Velazquez, thank you so much. And to all of our listeners, thank you for joining us. And we certainly look forward to joining again next Friday when we will be presenting another lecture, and hope that all of you will be there, and hope that all of you stay safe. Thank you once again.
Have a great day. Stay safe.
Bye.
Ciao.
Bye-bye now.